يا بليز. وخلاص الدكتور بدر الفلور is yours and دكتور عبد الوهاب.
طيب.
Okay, so everyone is here.
ما شاء الله. It's a great number. طيب، بسم الله والصلاة والسلام على رسول الله. السلام عليكم جميعا. On behalf of Family Medicine Academy of Medina, we would like to thank Family Academy webinar coordinators, our trainer, our mentor, Dr. Aisha, and her great team, Mr. Fiki and Mr. Rufaidat, for giving us an opportunity to share and participate in this valid webinar. And also, I'm so glad to introduce my trainer and my mentor when I am resident in residency program, Dr. Abdulwahab Al-Ghamdi. And he will give us a nice talk and love talk about an interesting session titled Overdiagnosis and Medicalization. Dr. Abdulwahab Al-Ghamdi, he is consultant family medicine and certified medical education. And he is very and one of the most active trainer participants in our academic activities. Dr. Abdulwahab Al-Ghamdi, the floor of yours and respected audience. يعطيكم العافية.
طيب، السلام عليكم ورحمة الله. أسعد الله مساكم بكل خير. I am Dr. Abdulwahab Al-Ghamdi from the Academy of Family Medicine at Medina. I am glad to be with you tonight. Very delighted to have with me this people of Saudi Commission of Health Specialties and people from the Royal College of General Practitioners and all my residents, mentees, and consultant trainers in different academies of family medicine all over the Kingdom of Saudi Arabia. I hope my sound is clear as far as I want to start.
It's very nice and clear, Doctor.
Okay, thank you very much. My background is experience, about 25 years experience in general practice and experience in evidence-based medicine, medical education, and research. And not all of these are my experiences, but just a few of them. But the most I'm very proud with is mentoring and medical education. I hope I will spend this session in an interactive way, and I hope that all of you will benefit from this session, inshallah ta'ala. Okay, the objectives of this session, inshallah, is to define overdiagnosis, medicalization, and related terms, to highlight the magnitude and importance of overdiagnosis and medicalization, to describe ethical issues related to overdiagnosis, and to list the causes, drivers, and consequences of overdiagnosis and medicalization in practice, to compare overdiagnosis and medicalization and related terms to diagnostic errors, to identify ethical situations where overdiagnosis and medicalization and related issues occur, to describe prevention methods. So let's start with this imaginary scenario about a patient who have a mammogram or have had a mammogram in your facility, in your primary care. Let's say this is Adria, she is 55 years, and mammogram showed calcifications, dense breast tissue. The BIRAS category 3 was put, and the radiologist asked her to come back in 6 to 12 months. After 6 months and several bookings, she had the diagnosis upgraded to category BIRAS category 4. And because of the dense tissue, he decided to give her a request for ultrasound, automated breast ultrasound, just because of the dense breast tissue. However, because of the results of BIRAS category 4, he decided to refer her to secondary practice or secondary care. You, before that, have examined her, and she showed that breast examination was within normal limit, and you found in history that she doesn't have any history of breast, ovarian, tubal, or peritoneal cancer. So you decided from your side that you should refer the patient to secondary care because you are afraid of ductal carcinoma in situ. Then your patient went to secondary care or tertiary care, and with the oncologist there and the radiologist, they have different requests just to confirm the diagnosis or just make sure that this is the right diagnosis. So they requested to do several tests and several requests, including dactography or galactography, including diagnostic breast mammography, as you can see here. If I can show with, okay. You have here a mammography of a patient who is having a diagnostic mammography. And you can see that there is calcification in the left side, and the skin is not tethered to this calcification on the right side, which might indicate a real tumor there. So just to make sure that the diagnostic process quality is going well, biopsy was requested, and the thing which was there in the minds of the secondary care physicians is to confirm the diagnosis of breast cancer or to rule it out. So if we look at the other side, we look at our patient Adria and see what is happening with her. If you put a stress meter and see what is going on, we see that most likely she will have this sort of, maybe she is in a coping stage or relaxed stage. Let's say she's a little bit stressed. With follow-up in secondary care, her stress will increase. Of course, now we are in the illness cycle. Then the doctors there told her that we need to make a staging for her breast cancer, and probably do dactography and probably different scans just to stage it. They might do magnetic resonance scanning or bone scan or bone scan or bone density scans. So positron emission tomography also might be used. So now Adria have reached her most, and she's near anxiety. This is the illness side from Adria. From the doctors, they want to do a quality diagnostic process. So they decided to do a biopsy. The biopsy could be a core needle biopsy or fine needle aspiration biopsy or a surgical biopsy and general anesthesia to make sure that Adria is asleep, because they don't want to make it painful. Unfortunately, as you can see that Adria has a small bruise there, and she took a lot of time to understand what's going on. The incisional biopsy sometimes could be done, or excisional biopsy, which we call it sometimes the lumpectomy, just to remove the entire lump or suspicious area, or sometimes they use the wire vacuum assisted biopsy. The reason for doing that biopsy is to take some sample and do microscopy that show the low-grade non-comedo ductal carcinoma in situ. And it was staged as 0. Depending on the staging type and sub-stages, providers may do hormone negative or hormone-positive cancer cells just to check the hormones, with estrogen hormones and progesterone and HER2, or they may do sometimes at the end they may do mastectomy, or may do sometimes exploration operation. After years of follow-up in the primary care and secondary care and tertiary care, and many visits and many investigations, many follow-ups, where her breast cancer continue asymptomatic. Her breast cancer showed no metastasis according to the recent scans and staging, and then she continued until the age of 77, where she has died of heart attack and kidney infection. Two things which are completely unrelated to her diagnosis of breast cancer. So what are the Adria have faced actually in this situation? We see that these different issues that we are talking about today, or false positive test result, which is not the case, over-diagnosis, yes, over-treatment, yes, over-detection, yes, under-diagnosis or misdiagnosis, no, overuse, yes, misdiagnosis, no false negative test result, no true positive test results of breast cancer? Yes. So these are the things which are true in this situation. So what are the problems Adria faced? Actually, if we look at that, this chart, which is a study about the mean depression and anxiety scores according to the self-reported results of maternal serum screening, this is another test, but for all diagnosis tests or screening tests that we do, there are drawbacks, there are anxiety, there is depression. So we could see here there is 27% of them, of the 87 people who undergo this test have significant increase in anxiety scores more than 5 points. And also 25% have, with the false positive results, have increased in anxiety scores. So now we come to our topic for the day, which is overdiagnosis. So this Adria or this lady had unfortunately been diagnosed, but unfortunately the diagnosis was an overdiagnosis, which is diagnosing a biomedical condition that in the absence of testing would not cause symptoms or problems or death in the person's lifetime. This kind of diagnosis can be harmful if it leads to psychological stress and unnecessary treatments. Overdiagnosis, on the other hand, is a correct medical diagnosis, and it is a true positive diagnosis. Importance in the realm of general practice or the realm of primary care, we call it the elephant in the examination room. That means the patient, the provider, they are concerned so much about this issue due to different socio-cultural reasons, including confusion surrounding the meaning of overdiagnosis, lack of awareness outside the realm of cancer screening, expectations about the healthcare. We know that we do screenings because we want to find diseases in the early stages, in low grades, so that we can cure them. However, sometimes screening discovered illness that would never cause any symptoms or problems even without treatment. Screening leads to cause illness. Illness is the patient perspective of screened disease. So we should, as family doctors, remember the issue of illness, that when we do any screening test, the illness will start, the illness cycle will start. What about the screening? Are we screening for cancer? We say that metastatic cancer of the breast cause 90% of deaths. When researchers went to this statement, they found that this statement is uncertain and this assertion is without proofs. They found that scientific papers refer to other papers that state the same thing. Papers refer to other papers that state the same thing, and few mushrooms claims that most cancer deaths are caused by metastatic disease are without any reference. So we can see that there is a lack of evidence, which make the picture even confusing for doctors themselves. Another problem with screening tests and the issue of overdiagnosis is the bias of overestimation of survival. Patients who are discovered by screening tests at early stages will have the problem of inflation of survival, which means that if we do not do this screening test at an early stage, the patient will survive in a similar basis. Some of them, of course, or the majority of them will benefit from the early screening. However, we should remember the percentage of overdiagnosed patients who are we are reporting as having more survival, while in fact they don't have. Yes. The second issue is the bias of overestimation of survival is the length time bias, where we tend to overinflate the survival by the fact that lead time bias or length time bias, sorry, can diagnose slowly growing tumors. We tend to say that this survival is increased, while actually the survival is not increased. It is due to the fact that we are discovering slowly progressive tumors rather than rapidly progressive tumors. Here you could see the 10 survival in the equation here is 10%. In the above one, where 1,000 patients with clinical lung cancer are followed for 10 years, we found the survival is 10%. While with the screening, we screened 4,000 patients, and we found that the 1,000 patients will develop symptoms later on, and the 10-year survival is 82%. So there is a great inflation of survival in this situation of lung cancer. Breast cancer we can have about 20%, prostate cancer 30%, thyroid cancer different estimation depending on the different parameters. Lung cancer also there is different estimation of the magnitude depending on different parameters. So we can say clearly that overdiagnosis might be an extreme form of lead time bias in screening programs. Here we could see the magnitude of the problem of overdiagnosis and overdetection in primary care. In breast cancer, for example, in Europe, 1 to 10%, in Canada, 12.4%, in 40 to 50 year, and 9.7% in 50 to 70 years. So the age is an important factor. It is more, we have more overdiagnosis in ages or younger ages than older ages. Prostate cancer screening with prostate surface antigen yields a big range of variability from 3% to 88% based on age and characteristics of population screened. Same thing for lung cancer screening using low density or low dose computed tomography. Sorry. Thyroid cancer, as I mentioned, there is a spread of imaging. They found that since 1995, there is a spread of imaging of thyroid because of the discovery of different techniques in sonography. So the people are doing more tests, and therefore there is an increase in thyroid cancer up to 83% of women across developed countries and 50% of men across developed country. So we can say that overdiagnosis variability can be due to age, gender, techniques, or technologies used, developing versus developed countries. So we know that in Europe, for example, overdiagnosis is less than in America, because in Europe they have probably they are cautiously using the diagnostic, or probably the technologies in North America is much more advanced for the early detection of tumors. In primary care based test and overdiagnosis, here we can see three scenarios. A non-progressive condition, which is labeled here with the pink or the red, and a slowly progressive condition, which represents overdiagnosis, and rapidly progressive condition, which represents the usual care and the concentration of secondary and tertiary and even primary care physician is on these people who are labeled here as in the curve as green. And you could say that the death at the end will affect people who are really having symptoms at an early stage compared with people who are overdiagnosed. Here in thyroid cancer, as I mentioned earlier, 1995 started a surge of the increase in prevalence of or incidence of thyroid cancers, and that was found all over the world, including the Kingdom of Saudi Arabia, as this article about the incidence of thyroid cancer in the kingdom from 2000 to 2010. That is a 10-year incidence. So they found that it is it's about 12% of all female malignancy are due to thyroid malignancy, and it is constitute 9% of all malignancy. So this is an issue. The issue of overdiagnosis could be here because we can see even in comparison with the USA, we are much we have much more common thyroid cancer than even USA. In South Korea, they find the same phenomenon, similar phenomenon, like Saudi Arabia. Let me see if I can use this laser pointer. Okay. As you could see here, for example, at this stage, since 2005, there is an increase of thyroid cancer. That is due to thyroid screening with ultrasound becomes available. So the presence of the screening test or the availability of the screening test can lead to overdiagnosis. It is one of the contributing factors. You could see here the death remains constant, which means that screening has increased the number of people overdiagnosed. Here in the cancer research in the UK, we find a similar thing for prostate screening. As you could see here, this side, patient without screening, this side, patient did BSA screening. They discovered 88 cases here and 68 cases here. At the end, 20 of the 81 will be overdiagnosed. So the mortality is similar in both sides, but the overdiagnosis is high in the size of the screening. Of course, we should not mix overdiagnosis with misdiagnosis or a wrong diagnosis. We should not mix it with false result alarm or false positive or abnormal finding, which sometimes happen if you do an X-ray or you do an ultrasound for a different reason and you found something else. That is not over the diagnosis. It was just because of the initial test or the reason of the initial test. Overdiagnosis is not a delayed diagnosis. It is not failure to diagnose unrelated disease. It is not failure to diagnose related diseases. It is not misdiagnosis, as I mentioned. It's not misdiagnosis. It is not failure to recognize complications. We want to do quality diagnostic process. However, these issues of overdiagnosis, overdetection, overtreatment, overuse, underuse, misuse, actually make quality diagnosis process more difficult, and we should be careful actually when we do, especially when we do screening tests, especially in an asymptomatic person. So adverse outcomes also make quality diagnostic process a problem. Diagnostic process failures, missed, delayed, or wrong diagnosis. This is an example of misdiagnosis. A patient with usually a patient with benign cyst will be diagnosed as cancer, or a normal patient labeled as having a cancer or having a benign cyst, or a benign cyst or a breast calcification labeled as cancer, or breast cancer misdiagnosed. What are the drivers of misdiagnosis in primary care? This includes disease screening, because these tests that we offer to patients have their drawbacks, which includes overdiagnosis, heterogeneity of cancer, and disease progression. We know that some tumors may grow slowly, others may grow rapidly, others may regress. As this curve is showing, we have three styles or three curves of growth. Let's say 4 curves. This is number 1, this is number 2, 3, and 4. In this situation, the growth of cancer is so fast, so the patient will go to death rapidly. In this situation, the death will come later on, and in patient with very slow and non-progressive or regressive tumors, the patient will die from other causes, And this is what we called overdiagnosis or pseudo disease. What are the causes? Changing diagnostic thresholds, lack of prognostic knowledge, multifactorial with many trade-offs. Here is what we mean by diagnostic threshold. If you have this patient, different patient groups here, patient have are normal people. We have high diagnostic threshold screening people, and we have low diagnostic threshold. We are screening with low diagnostic threshold test or criteria. So in the high diagnostic threshold, we find that the number of overdiagnosis is reasonable. While if you use low diagnostic threshold, the number of patients is 5 times likely to be overdiagnosed than the number of patients with high diagnostic threshold. So threshold of diagnosis or criteria of diagnosis should be, as we say, case finding rather than screening, because we do case finding for patients with high risk, with high diagnostic thresholds. We also know that we lack knowledge of the prognosis. For example, if you take breast cancer, age of the patient, estrogen treatment, type of cancer, tumor grade, menopausal state, Ki-67 index, receptor status, all are prognostic factors. So which one is playing more role than the other? Which one is, how can we use all of them to decide the prognosis and the progressiveness of tumors? Okay, I can see now I have, can you just move the picture just aside a little bit from the corner? Okay, what are the factors affecting, excuse me, Dr. Badr, if you can move the camera to the corner, if you can, or some side, because, okay. So what are the prognostic factors and what is there? For example, the Ki-67, we say if it is less than 10%, we consider it is low. That is, the tumor, the breast cancer will not progress to become metastatic. 20% or more is considered high, more likely to be aggressive and spread quickly. So what are the consequences of overdiagnosis? Depending on the medical condition. Yani sometimes you can overdiagnose a self-limiting condition. Yani apple disease which is self-limiting, that it will not be a problem. Lakin if we say that the patient is having cancer and if we break the bad news and told him that you have cancer, then this is really a diagnosis that have a major impact on the patient life. And it is really a dilemma for physicians and for healthcare providers how to deal with overdiagnosis. You know, overdiagnosis is a retrospective diagnosis. We don't know what will cause the death of the patient. Patient may die from cancer of the breast, or he might even not die from cancer of the breast if the tumor is slowly growing or if the tumor regress. Okay, let's take the scenario of metformin, for example. When you prescribe it for pre-diabetic patients, should we prescribe it or not? This is an example of overdiagnosis or overuse. When we say a patient is pre-diabetic, for example, here Davidson in Diabetes Care, he mentioned that metformin should not be used to treat pre-diabetes. And the reason for that, he said, is 2/3 of patients of pre-diabetes will not progress to diabetes. So why should we treat 2/3 of patients while 1/3 of them will go to develop diabetes complication? However, the issue does not settle at this level. Hartman and Ratner also contributed. They say that metformin should be used to treat pre-diabetes in selected individuals. So that according to this statement, we can select the individual, the high-risk individuals who can develop complications like microvascular complications, retinopathy or nephropathy or peripheral neuropathy or other complications. inevitably or unavoidably will have overutilization. If we overdiagnose, we'll have overuse, overutilization, and overtreatment. We will insult the patient psych. We will have a psychological harms. We will label the patients, and we will cause unnecessary financial costs to the healthcare system. But this is almost unavoidable unless if people try or policymakers try to make a strategy or some sort of prevention programs to prevent overdiagnosis among physicians all over the world. Actually, it's not a problem here in Saudi Arabia, but it is a problem all over the world. So overtreatment is another issue which can arise from overdiagnosis, which is unnecessary treatment of condition. Any condition that you unnecessarily treat is overtreatment. Yes. Okay. Low probability. Excuse me.
قول سوى.
Can you mute everybody, Dr. Badr? Can you mute everybody? Just until you finish until you finish.
Go through, Doctor.
So low probability of benefiting the patient or harmful instead. So this is overtreatment. It might be harmful, but it is probably inevitable cause of overdiagnosis. Overuse is use of unnecessary health services for which protection or potential harms outweigh potential benefits, like using tests or treatments. The association between overuse and overdiagnosis is a little bit complicated, broader term than overdiagnosis. Overuse is broader than overdiagnosis, and overuse is a cause and driver of overdiagnosis. For example, 10% of patients with angioplasty who do angioplasty are actually this angioplasty is overused. And therapy for cancers which do not respond is considered an overuse of therapy for cancer. For example, using medical tests like procalcitonin for lower respiratory tract infection. You know that procalcitonin is a precursor of calcitonin, the hormone that you know. Sometimes they use it to guide antibiotic treatment for respiratory infections, but this is considered overuse. Incidentalomas is due to overuse of MRI and CT studies in lung cancer, for example. It is or other types of cancer. Whenever you use MRI or CT, there will be incidentalomas and the issue of overuse of these diagnostic modalities. 9% of women dying of stage 4 are still screened with mammography. So what is the benefit of screening of a woman who already have cancer? So this is an example of overuse. Computed tomography, lung cancer screening is also sometimes can be overused. Misuse is the provision of an appropriate service where a preventable complication interferes with patient benefit. It is a fundamental quality problem related to patient safety. Misuse may arise while treating an overdiagnosed disease. There is difficulty in screening overdiagnosis in clinical scenario in the real time. We mentioned that previously, that overdiagnosis is retrospective diagnosis. You cannot diagnose overdiagnose or tell whether patient has overdiagnosis in the real time. It is later on when the patient does not develop symptom and when the patient dies without the reason of the issue that you overdiagnosed. There are ethical complications for overdiagnosis, including the resulting label. That is, we are labeling the patient with that diagnosis or the intervention. We are labeling the patients, and the balance between benefits and harms is unfavorable. Ethicists will divide overdiagnosis into two types: avoidable and unavoidable. The unavoidable is called tragic because it's really tragic, because it is either benefiting and it is other benefiting, while the avoidable type is called predatory or misdirected. Predatory when it is self-benefiting, when a physician do a test or screening test to benefit himself either financially or academically or for any reasons, then this is a type of predatory avoidable overdiagnosis. Misdirected when it is avoidable and other benefiting, or when the diagnostician do a test to benefit others, this is considered misdirected avoidable overdiagnosis. The problem of counterfactuality, which Hoffman described as it is impossible to know what would have happened if a screened person had not been screened. يعني انت ممكن تشخص شخص وبعدين with screening وبعدين انت ما في الاخر ما حتعرف اذا كان الشخص هذا لو ما اخذ السكرينينج تيست ايش اللي هيحصل له. Okay, you screen a person and then you find a positive result. If you don't screen this person, what will happen to him in the future is the problem of counterfactuality. Medicalization is a close term related to overdiagnosis, and it is widely employed by social scientists or medical sociologists. And medicalization is the process by which some non-medical aspects of human life become to be considered as medical problems, thus become subject to medical study, diagnosis, prevention, or treatment. طبعا this was started by this scientist 1950. I thought the late scientist Talcott. He's a medical psychologist, and he is the one who have invented the term medicalization. What are the drivers of medicalization? Evidence or hypothesis about conditions, changing social attitudes, economic considerations, the development of new medications or treatments or managements. For example, when you have a new management for any disease, that people will now socially will be attracted to this management. Whether the patients will benefit from this and using it as a screening test is another issue. It will bring all of these issues of medicalization, overdiagnosis, over-treatment, and even sometimes mistreatment. There is similarity between medicalization and overdiagnosis. Both critique unwarranted or contested expansion of medicine. يعني كلاهما ينتقدان التمدد في الطب. We know that the umbrella of medicine has in the last 50 years have so much become inflated, and it is covering everybody in the social or in the social system. So the people in medical sociology are thinking that we are really over expanding and over interfering in the lives of the people. Sometimes, and most of the times, fortunately, this interference is excellent and it brings about good health, but sometimes it can bring medicalization and overdiagnosis. Not all cases of overdiagnosis are medicalization, and not all cases of medicalization are overdiagnosis. Overdiagnosis has been biological or biomolecular conditions or processes acknowledged being potentially harmful. This is overdiagnosis. When overdiagnosis is related to biological and biomolecular conditions, while medicalization is concerned with indeterminacy, overdiagnosis is concerned about lack of prognostic knowledge. Medicalization is dealing with sickness, so therefore a sick role, while overdiagnosis is dealing with disease. Medicalization is expanding, encompassing the more ethical, technical aspect of overdiagnosis. يعني medicalization هو encompassing overdiagnosis now. Overdiagnosis is becoming more ideologized. Medicalization will become all-encompassing with new trends in modern medicine, such as the before model, which is preventive, predictive, and the other aspect of the before model. Medicalization at the end will and overdiagnosis might converge into some larger iatrogenization. So iatrogenization may all encompass all of these terminologies, and in the future we may see that iatrogenization will become the term which is including overdiagnosis and medicalization. We have also over-medicalization, which is excessive use of medical diagnostic and procedures for conditions and complaints that do not warrant such cost and time-intensive practices. So in over-medicalization, we tend to use the cost effectiveness as a parameter of over-medicalization. Overuse of medical diagnostics and procedures. It leads to increased expenses, takes away from patients' ownership of managing his or her conditions. Outcomes are often indifferent or worse than other options. For example, if you have, this is common in musculoskeletal disorders, where you can use movement therapy for treatment of many conditions, of musculoskeletal conditions. However, people may go to do, for example, to use drugs or to use other modalities of treatments that may not actually even affect or have any good outcomes than motion therapy or movement therapy. Over-medicalization examples: magnetic resonance, MRI for non-specific low back pain, arthroscopies for non-traumatic knee pain, shoulder joint debridement for shoulder pain. For these are all over-medicalizations. What are the consequences of over-medicalization? That induce a certain risk to the patient, may introduce risk to patient, debilitate the patient following the surgery, reduce the patient's role in the rehabilitation process, yield no better outcomes than the other alternative less or cheaper modalities of treatment or available modalities of treatment. The dysfunction, this is most important. Sometimes the disease that which is over-medicalized does not get addressed. So this is really a big problem with over-medicalization, an important problem. Over-detection is the same as over-diagnosis. The emergence of sophisticated self-testing technologies, greater access to test, and in some cases commercial incentives. So this is, and commercial incentives come to play a role in over-detection. Disease mongering, encouragement of over-medicalization by outside forces to maximize profits, and a strategy pursued by drugs industry to create or broaden drug markets. Yani, drug industries, they want to broaden their markets. They use this disease mongering strategies. Sometimes depending on real evidence and evidence-based process, sometimes just inflating the statistics and misleading the society and even the healthcare providers to prescribe different diagnostic tests, which are actually unnecessary, and they contribute to mongering and overdiagnosis and over-medicalization. We have, for example, the ordinary life disease mongering. For example, menopause is medicalized, being medicalized. We know that all societies in the world, the woman goes to menopause, but they don't really probably will have any problems because of menopause. But the fact that some benefits for drug companies, they sometimes promote certain drugs or promote certain research facts or certain unnecessary information just to make sure that they profit from this promotions. Mild problems portrayed as serious illness. like, for example, if you have any pain in any part of the body, then they will concentrate on that, and they'll make it as a disease or a sickness. Risk factors such as high cholesterol, osteoporosis, being framed as diseases. So these are examples of disease mongering. So we have to be careful as family doctors not to embark or to participate in such process, because they lead to overdiagnosis. Using mass media, they use mass media to push certain view of a particular health problem. They use also informal alliances with doctor groups, with public relation companies, and patient advocates, just to propagate a problem, a minor problem, as a disease, and then will push us into the overdiagnosis and over-medicalization cycle. Okay, what should we do to overcome this problem? There are many suggestions and many advices, and as you all know, the Choosing Wisely initiative, which was done or was proposed by the American Board of Internal Medicine, which is we should use screening tests, we should use tests, we use drugs in a rational way, in high-risk patients, in patients we know that we are going to find benefit, and we should always balance the benefits and the harms. If we think this drug is going to cause more harms to the patient, if we think the patient will survive with a good quality of life without using these drugs, probably the Choosing Wisely will be a good rationale for all doctors all over the world to choose rationally. This initiative was also supported by the American Academy of Family Physicians. And not only that, the American Academy of Family Physicians have issued a guideline for 20 things physicians and patients should question. In other words, any tests, any intervention, any diagnostic process, any advice, any screening test, any screening questionnaire should undergo a certain sort of questioning from both the patients and the physicians, especially the family doctors, because they are the first contact line, and they are the ones who are going to screen the patients most of the time. They are going to using the periodic health maintenance test all the time. So I think it is a good thing to look at some of these 20 things that are issued by the American Academy of Family Physicians, including not doing an X-ray for a patient with back pain in the first 6 weeks unless there are red flags, or not prescribing antibiotics for patients with sinusitis unless symptoms last for 10 days or more, not to do DEXA unless the patient, if the patient is less than 65 for females and less than 70 years for males, especially if there are no risk factors, and not doing ECGs annually if there is no risk factors, especially if the patient is low risk for cardiac events, and not doing pap smears for women younger than 21 years who have had hysterectomy for non-cancer disease. The list is so many, so you have another 20 recommendations by American Academy of Family Physicians. You can refer to them in the literature. You will find them right where they are published and free to access. So in summary, let's just summarize what we are saying, that the problem of overdiagnosis and overtreatment is complex. Yes, it is complex, but we can deal with it. And today is considered an introduction for all of us to realize this issue. So we know that it's complex, but we can understand it and we can deal with it. It has numerous causes and many trade-offs. overdiagnosis and overtreatment have serious implications for individuals, healthcare systems, and society. Asymptomatic people may continue to do so as cancer disease never progress, regress, or slowly regress. Diagnostic process errors and unnecessary screening tests and therefore unnecessary diagnosis, misuse, and overuse affect quality. Death, disability, or symptoms causes may not be related to your clinical decisions or screening or management. يعني انت ممكن انت تكون تعمل management ل certain condition لكن المريض ممكن يعيش asymptomatic لكن كيف تكتشف انه هو عنده الكونديشن while he's overdiagnosed is unfortunately is a difficult and complex issue because as I said earlier, it is a retrospective issue. You can't say the patient is overdiagnosed unless at the end. When the patient dies, you know that the patient died from other diseases and the patient does not suffer any symptoms in later life, and you know that now you are overdiagnosed. And as family doctors, you should realize that and you should stop giving any management or any treatment in any patient whom you think the patient will not benefit from the treatment, or if you think that the symptoms which is arising in the patient are not related to this illness. Of course, warning about the dangers of becoming inappropriately labeling people as ill, as this will provoke the illness cycle. As you know, the illness cycle is the perspective of the patient, what the patient feels, what the patient expects, what the patient suffer, the anxieties, the depressions, and all of these things that will arise from overdiagnosis. So we should be clear about overdiagnosis and over-medicalization and medicalization in the future, and we should stop unnecessary tests, unnecessary treatment, unnecessary management, unnecessary advice, and we should not medicalize the life of the people. We leave the people live their normal life without intervention unless really we find that the benefits are much more than the harms that we could do by these interventions. Thank you for listening. And if you have any questions, I'll welcome them. And at the end, I want really to thank the people in the Saudi Commission of Health Specialties and all the residents who are listening now, and the people from the Royal College of Irish Royal College of General Practitioners for this great initiative of making webinars so that the residents all over the kingdom can benefit from this initiative. Thank you very much.
Thank you, Dr. Abdul Wahab. And that was very remarkable session, and was very helpful and meaningful session. We learned and we joined and we learned a lot of new medical terminology. And if anyone of the audience has a clinical experience, his or her participation is very appreciated. Dr. Aisha, Mike, Dr.
حياك الله. Thank you so much. Thank you so much, Dr. Abdul Wahab. يعني really يعني it is like music in my ears. The overdiagnosis is a new concept in which we would like to encourage it. Choosing wisely, just I want to raise, as Dr. Abdul Wahab, he was mentioning about choosing wisely. Now in the Ministry of Health, we started the Choosing Wisely initiative, MOH, or Saudi Arabia Choosing Wisely initiative. Alhamdulillah, I'm proud that I'm the physician-led in Choosing Wisely initiative now in the Ministry of Health. And we are starting to have campaigns, and awareness will be started very, very soon with the collaboration with Saudi Commission of Health Specialty. as it has been mentioned, choosing wisely was started in the United States, but now it's an international campaign looking for preventing the harm for patient, which is related to using or prescribing or requesting unnecessarily labs or medication. To avoid this, avoiding this is to reduce the harm and improve the value of care. Thank you, Dr. صراحة عبد الوهاب, for this very important.
Thank you very much, Dr. Aisha. I really am glad to hear that there is an initiative like that in the Ministry of Health.
Yes, yes.
And I think all doctors all over the kingdom, especially family doctors, because they are first contact, they are the people who are doing the screening test. Usually they are the people who are doing that and overseeing this process like the mammogram and the other diagnostic or screening tests that we use. I think it's very important to choose wisely, to question some of our daily practices that we are doing from time to time. Yes, you're right.
طبعا we did a survey. Actually, we did 2 pilots, which one of them was conducted in Taif, another one was conducted in Hafr al-Batin. And we did a survey for the physicians in the field. What has been discovered now, as all of you know, especially in the Ministry of Health, as all of us are there in this part in the primary care in the Ministry of Health, because of the limited resources in the primary health care, the overprescription or unnecessarily is still not a main issue in the primary care. The main areas in which there is a lot of unnecessarily tests done is in the hospitals, especially in the ER and the ICU. And this has been done through the studies which has been conducted now and the surveys in MOH. And that's why the priority of the Choosing Wisely campaign now in the MOH started in the ER and the ICU and the inpatient services in the hospital. It will be extended to the primary care as an awareness campaign all over the kingdom. In alignment of the Choosing Wisely, because we need Choosing Wisely is usually led by physician, because most of the things are يقول لك توقيع الطبيب هو اللي يبدأ the signature of a physician by requesting the labs or prescribing medication. This is it should be a physician led. The second thing, it should be evidence based. So the clinical practice guidelines and the best practice guideline should be aligned with this. And also the media and the stakeholders should be there, because when we do the survey, and we are part of the world, and also it's all over the world, and you ask the physician why you are doing this, most of the replies is because of the patient request. For example, the antibiotic, for example, the CT request or the X-rays. And some of the physicians, they are doing it because they want to have a safe practice, not to miss. It needs to be aligned. When we are in a Choosing Wisely campaign, you need to be dependent on the best practice guideline, and you are supported by the stakeholders, because if it's implemented in the HIS system or in the protocols, it will support the physician in their if they are not replying to the patient request. Now, especially in the Ministry of Health with the 937, in which we have the complaints of the patient, they go and give a complaint against the physician. If the physician is supported by the protocols and by the stakeholder and the system, this will reduce of the over diagnosis or over utilization of the things. I'm so happy that Dr. Abdul Wahab has raised this issue, and I was going to suggest that we have a Choosing Wisely lecture in the webinars next year, 2022, and this is Dr. Mashallah Abdul Wahab. He started this issue and he started this topic and on this part. يعطيك العافية دكتور.
Thank you
This
very
is my
much.
comment. Yeah.
I just want to hear from the residents, Dr. Badr. If you can hear any resident or any...
Yes, Doctor. There is many great question chat box, but
Okay.
before
If you have anything-
we take from Dr. Sami, Dr. Sami Al-Ruhaili, one of our trainer.
He's welcome.
Yeah, Dr. Sami, it's for
حياك الله يا دكتور سامي.
Yeah, حياكم الله. السلام عليكم. Good evening all. I'm amazed actually, Dr. Abdul Wahab. You are inspiration to us all. Actually, I heard barrels today. Tackling medicalizing medicalizing the practice has too many dimensions. Being interested in nutrition and lifestyle, in recent years, we are having a tablet answer to any complaint, even minor complaints. Yani, sometimes we receive a patient with blood pressure, which is just 1 or 2 marks over the normal reading, and the pressure of peers and patients force us to prescribe medication for that very simple elevation in or abnormal reading, which can be tackled by reducing
lifestyle, yes. By lifestyle management, yes.
Yeah. This is one issue. The other dimension is we are making a new illness behavior in patients. If one patient with a simple back pain after lifting a heavy object in his home or at his home, and this simple pain 100 years ago used to be treated or managed by rubbing oil in his back, and that's it, and he will be healthy and wealthy, young, with clean bill of health. What is happening right now, this patient will visit the doctor. Majority of doctors will do an MRI or CT scan and prescribe very powerful non-steroidal anti-inflammatory drug. If you differ from that practice, what will happen? You will be sued. You'll have a complaint against you, or minimally your reputation will be ruined. You are هو من جيبك من كيسك يا دكتور. Do it for us. And this is fixation of a new way of treating patients. That if you have any pain, which is 1 or 2, it needs a CT scan or a arthroscopy. In fact, يجدادنا a cane in his hand, عصاية في يده, ويمشي حياته يتكئ عليها وتمشي الدنيا. So this is يعني besides the economical impact. يعني we are now noticing that medical expenditure is exploding. It's not only inflating. It is like
Dr. Sami,
anyway, I had a call. This is what I have. Thanks.
Thank you very much, Sami. Thank you very much for your contribution. Dr. Badr, if you have... Thank you. If we have any questions from
Dr. Abdul Wahab, there is always time pressure we face it. And your conflict of time and the prayer, you know this, and should we, inshallah, will be closed in not more than 2 minutes. There is many great questions. We have in the chat box. The first question from Ali. Could you please clarify how osteoporosis is considered a medicalization, not a disease? This is from Dr. Ali Al-Khalaf.
What can you say?
Could you please clarify how osteoporosis is considered medicalization, not a disease? This is his question. You can use the mic if there is a question not clear.
Osteoporosis, osteoporosis is a disease. It is not medicalization. You see, the overdiagnosis, we are dealing with real diseases. However, these diseases will not be symptomatic at any stage of the life of the patient. They will not affect the life of the patient. The patient will live to 99 to 100. He will not have any symptoms from what we are diagnosing. So if osteoporosis And this is the dilemma about overdiagnosis. The osteoporosis will happen in a person, and he will live to 100 years, and he will die from, for example, an MI, and he will never develop any symptom related to osteoporosis. Then we have done what's called medicalization or overdiagnosis. But unfortunately, we don't know in the real time what will happen to that patient. This is a dilemma. This is the dilemma even for the aesthetists and for the healthcare providers. We should be aware the decision making of screening should be based on discussions and shared understanding between the patient and the doctor. We should avoid the habit of even for recommended screening of doing the screening without telling the patient. In fact, what we are doing, for example, for breast cancer, we are trying to increase the reuptake of breast cancer screening. We are doing media advertisement, and we are doing a lot of things to increase the uptake of breast mammography, for example. Lakin, we should know as doctors that this can have its own drawbacks, which is overdiagnosis and medicalization. However, osteoporosis أعود للسؤال، أنا ما أقدر أحدد. أنا إذا طلعت إن واحد عنده osteoporosis ما أقدر أعرف إذا كان الشخص هذا حيجي symptoms من الاوستيوبروسيس أو لا. حتى الإيثيسيست يقولوا أنت تكون نبي أو تكون رسول أو تعلم الغيب إنه الشخص هذا حيصير عنده symptoms أو he will die from complications of osteoporosis.
ثانك يو دكتور عبد الوهاب.
دكتور عبد الوهاب إذا تسمحوا لي. طبعا هي الإشيو هنا إنه بالذات يعني choosing wisely campaign is about a conversation between patient and physician, and this conversation because the patients need to ask, and even the physician need to ask 5 questions before prescribing or requesting a medication. Is it necessary? Is it the only solution? Is there any side effect? What is the cause? If I didn't do anything, what will happen? And it should depend on the best practice guidelines. يعني, we cannot avoid from the best practice, although we need to tailor it with the discussion with the patient. And here is يعني هي الدايلما اللي قاعد بيتكلم عنها الدكتور عبد الوهاب الآن، إنه we need to have a clear evidence that we need to do this thing, but we need to tailor it according to the scenario of the patient with discussion with the patient. This is a priority or no. لكن we need to be attached to the evidence. What is the best? What is the recommendation? What's the best practice? When to do and not to avoid this from our practice. يعطيكم العافية.
أعتقد الدكتورة عايشة فيه قضية إنه البيشنتس themselves لازم يعرفوا إنه إذا إحنا عملنا لهم سكرينينج تيست، أي سكرينينج تيست، إنه في إيشو أوف أوفر دايجنوزس. بمعنى إحنا لازم نقول للمريض إنه أنت ربما إنك تعمل السكرينينج تيست هذا ويطلع عندك مرض، لكن المرض هذا ربما لا يؤثر على حياتك نهائيا. واحنا صراحه كاطباء عاجزين ان نعرف هل انه المرض هذا حيأثر ولا لا. احنا نعرف انه مثلا 2/3 مثلا البري دايابيتس، نعرف انه 2/3 will not go to diabetes, will not develop complication related to glycosuria لكن glycemia. لكن احنا ما ندري منهم هل المريض هذا اللي قدامي انا بعمل له التست حيكون فعلا من الناس ذولي ولا من الناس اللي حيستفيدوا لانه حيقلل الكومبليكيشنز اوف جلايكوزيميا. فهنا الفكره الديلما هذه حقيقه لازم المريض نفسه يعرف.
هي الاشيو كمان الثاني when you do it when it's not necessarily. يعني انا اعمل سكرينينج في الايج اللي not appropriate ولا في التايم اللي is not appropriate. I'm not attached to the بس يعني ماموجرام مثلا at earlier stage مثلا patients with no risk factors مثلا I start to do a fasting or A1C which is not in the age. فهي if we attach to the guidelines this will reduce it unnecessarily لكن it will reduce لكن it will not prevent it. ايوه فاحنا مشكلتنا في انه بعض الاحيان we don't attach even to the guidelines. يعني يجي البيشنتس تعمل له سكرينينج يقول لك روتين، كلمه روتين هذه المفروض تتشال. ما في حاجه اسمها روتين.
Yeah.
في حاجه اسمها CDC الان جايد لاينز ايش تقول لك appropriate to the age. You do the screening وهذا المفروض we as a family physician we do it appropriate to the age. نفس المشاكل اللي بتحصل الان ويجيك البيشنتس راح للاب في مختبر خاص وجاك بلستة حاجه اصلا يعني ما مفروض يعملها واكتشف شيء فاضطريت انت تعمل شيء ثاني بعده.
discovered accidentally.
ايوه
As
discovered
usual,
accidentally.
مثل يا دكتورة يسووا تخفيضات للموضوع، يعني انت اذا سويت ذا هنعمل لك ديسكاونت كذا، اذا سويت الكومبليت انفستيجيشن قالوا الامبريلا انفستيجيشنز you will benefit so and so you will add you a CBC and ESR.
صح. انا جتني مريضه في العياده عامله كورتيزون ليفل، انا ما قد شفت احد عمل كورتيزون ليفل، قالوا لي انت فتيكد وجايبت لي كورتيزون ليفل قايزين لها اياه AM، قلت لها من يعمل لي الكورتيزون ليفل؟
diagnosed question.
فيعني anyway يعني to go يعني at least you go by the best practice، يعني هذا يقلل الهدر كثيرا، لا يمنعه لكن يقلل. If we do something is not appropriate at the age or the time which is inappropriate will lead to another inappropriate thing. معلش I know إنه الوقت الموضوع ذو شذون والوقت يمكن ضيق.
Definitely.
نشوف الأسئلة.
Yeah, there's for the sake of time we cannot take not more than a question, but definitely it's very important screening tools for early diagnosis, but should be balance between how this way is true to guide us for diagnosis or can be overdiagnosed. Many thanks to Dr. Abdul Wahab. Many thanks all of our respected audience. I think no more question to be taken. We learned a lot from this session. We learned a lot of medical terminology. Thanks a lot, Doctor, for this remarkable session. I think we now to be closed. If there is, if anyone have any kind of question or can use the mic before we end this session. يعطيك العافية دكتور عبد الوهاب. يعطيكم العافية.
I'm listening. If anybody have any question or any remarks or
please answer the survey before leave.
Thank you, Dr. Badr. Yes. So thank you everyone for attending the webinar. This is Rufaida from Saudi Commission of Health. شكرا دكتور عبد الوهاب الغامدي. Thank you so much for providing all of this information. Thank you everybody for attending. الله ينفع بعلمكم إن شاء الله ويجعله شاهد لكم لا عليكم. Thank you doctors for being there here with us and for being cooperated. Please, if you can answer the survey down here عشان we can serve you better in the future.
Thank you very much.
Thank you, Rufaida. Thank you for great.
Thank you, Dr. Badr.
Okay, thank you very much, everybody.
Thank you. Have a great rest of night.
سبحانك اللهم وبحمدك أشهد أن لا إله إلا أنت أستغفرك وأتوب إليك.
شكرا.